Yes, let me just make you co-host. Can I do that? Oh, great, you did that. Thank you, Hannah. You're good to go, Dr. Chan.
Perfect. So I'm gonna I have about 30 minutes and I got a bunch of very pertinent, wonderful questions. So thank you for all that. I wanted just to start off by giving you kind of a high level what we're seeing across the US actually. And this is, this is what comes from the CDC website. So I think this is important for the advisory group to know just what's happening nationally, where the focus is. This is also the data, which should guide in part our state response. And so pay attention to how it's phrased and messaged and kind of what the goals are here. So I think just starting out, just to mention again, we're actually making great progress here in Rhode Island. We've, been a model state, in my opinion. We're about 30% down in new HIV diagnoses over the last decade plus. So, and this is really a tribute to the team in Rhode Island. There's so many of us, everyone on this call, certainly the Ryan White program, certainly the Department of Health program. It's really been a team effort, Immunology Center, the other clinics out there. It's been a team effort by all of us here in the state related to HIV, and it shows. And I guess I just want to offer those words of encouragement that it's working. What we're doing is working. Now, there is still work left to be done, as you all know, but there are definitely some positive trends that we're moving in the right direction. And you can see here, and as we talk about groups most affected, and I just wanted to show these numbers because they're always a little bit sobering and bring us back, to reality here, is that I'm always struck by gay and bisexual Black men, especially, are really by far the number one risk group here in the U.S. Just disproportionately. I mean, the most number of HIV cases are still being diagnosed in Black African American men, second to Hispanic Latinx men as well. And so I'm just reminded that we need to do more to address HIV, disparities, social determinants of health. That really one of the focuses here in Rhode Island and nationally, in my opinion, but in Rhode Island needs to be among reaching communities of color for HIV care, as well as for HIV prevention approaches, things like PrEP, et cetera. So I know that's not new to anyone here, but the data continues, unfortunately, to reflect that. And I just want to highlight that as an important note here. The other thing I think that's not surprising to any of us is that younger folks generally still are those who are newly diagnosed. We're looking at 20s and 30s. You can see here we are still certainly seeing a number of older folks in their 40s and 50s and older. But a lot of the majority folks are younger, in their 20s and 30s and early 40s. And I think this just drives home some of the disparities that we're seeing. Still a lot of disparities related to race, related to ethnicity, really points to the fact that we need to do better. I think one thing that we've been lucky in the Northeast again is that as we talk about HIV across the US, and I just wanted to provide this snapshot, is that a lot of resources for HIV are going to the Deep South. And you can see here that the South really has some of the much higher rates of, frankly, everything, but in this case, HIV as well. And so just as you look at the national landscape, Congress, federal government, they are pulling some resources away from areas like the Northeast and focusing more resources on the Deep South, because that's where we're seeing more HIV diagnoses and just worse outcomes as well. And that's just something to keep in mind here. I know that Paul and Garlette and others at the Ryan White program here in Rhode Island have done a really awesome job advocating for resources for the state of Rhode Island. And I think sometimes we're victims of our own success, meaning we have done relatively good job, as we mentioned, but because there's other states that are not doing as good, they are at times pulling away some resources away. And this is also good for us to remember, is that, again, a lot of people in Rhode Island know their status, but about 12 to 13% of people still do not know that they are infected with HIV. And that's been a focus of public health efforts and other efforts, is just to make sure that people know their status, right? That's the first step of the HIV care cascade. If you don't know you have it, how can you get on treatment and get in care, et cetera? So really important for folks to understand their status. And at the end of this, just as I'm talking through this, by the way, I would love to hear from you all about what you think. And maybe this is one of your questions, Paul. So sorry to jump on it, but I would be curious myself to know, both as someone that works for the Department of Health and both as someone that works closely with Paul and Garlette, what we in Rhode Island can do better, whether or not it be for HIV care outcomes or HIV prevention. Are there any gaps that you think that we're not doing well? I think there are some things we're doing well. I think there's always some things we can improve on, but we'd love to hear from this group in a few minutes about things that we can do better and where we need to focus some of our efforts. And the other thing I want to mention, because we talk about HIV a lot, but I want to include this one slide about other sexually transmitted infections. So if you look at the numbers of HIV, they are coming down over the last decade. But if you look at things like gonorrhea, chlamydia, syphilis, we are seeing steep upward increases in these other STIs. So HIV is obviously an STI, but these other STIs, I think sometimes, I do think a lot of times they are less serious than HIV, but some of these are totally significant, especially syphilis, and gonorrhea and chlamydia can be more significant. But we need to keep in mind that as we talk about STIs in general, like we can't ever eliminate HIV if we don't get a handle on these other STIs, because having one of these other STIs, right, you have inflammation and breaks in your skin and irritation and ulcers and sores. And when you have those, HIV can more directly enter your one's body. So all these other STIs increase the risk of HIV acquisition by anywhere from 3 to 5-fold. And that's been well reported in a lot of scientific literature. So we need to do better just of STIs in these other STIs in general. Okay, questions. Okay, these were the questions right from the group. So I'm going to pause at the end of each question to see if there's any, anything else you want me to answer or any other questions. So the first question that we have here is, really, how do doctors know what ARVs should be prescribed? I mean, what is it? Is it random? Are we pulling it out of a hat? You probably go to your doctor. A lot of you probably go to your doctor and it's like, how do they even know what they're doing? Well, as many of you know, treatment used to be incredibly complicated. And I know there's been a number of folks that have had HIV for a long time, 20 plus years. And it used to be, AZT, every 4 hours, handfuls of pills, set the alarm clock. And we've come a long, long way. And these are, these are all the drugs that are currently approved by the FDA. And some of these are really old, right? If you look on the right-hand column, I mean, there's some that are like discontinued now, which is a good thing, right? Because some of these drugs had terrible side effects, and we'll talk more about the side effects in a second, but there's a lot of pills here. How does your doctor know which one to use? And to confuse matters even more is, some of these pills contain one medication, some contain 2 medications, some contain 3 medications, right? So you never know. And I find that other doctors get confused, when you go, when people are admitted to the hospital, it's like the doctors are like, well, the other doctors don't know. So it's helpful for patients to know and to advocate for themselves. And I also spend a lot of time, and I know a lot of my colleagues do, just educating some of the other providers about, what's a reasonable HIV regimen. And so historically, right, so this is in the past decades, used to be that you wanted to be on 3 drug combinations. We generally used to talk about there being a base drug, which was a protease inhibitor or a non-nucleotide reverse transcriptase inhibitor. So PI used to be like Kaletra or atazanavir, or no, not that one. And an NNRTI used to be like efavirenz or nevirapine. And then there's a backbone, which was generally 2 NRTIs, nucleoside reverse transcriptase inhibitors. And those were like AZT or DDI or DDC or things like that. And what's changed, and historically, you never wanted to use one drug. You never ever still want to use one drug ever, one medication. You want to keep in mind, of course, that one pill can have multiple medications, but you never ever want to treat HIV with just one medication. And you generally don't want to use two or three NNRTIs. So we're phasing out AZT, or ABC, abacavir. And, all these drugs, and this is one of the marvels, actually, I'm not going to go over the slide, just, but, one of the marvels of HIV treatment is that we've really understand the pathways and the life cycle of HIV now. And this is a scientific marvel that we've been able to develop these drugs that really interfere with like every single small step of the HIV life cycle. I mean, it's really one of those examples where basic science, all these scientists, at Brown, but, Harvard and other places really have trickled down to providing, these treatments. So things done in the lab have really led to these, miraculous medications now. And so when your doctor's prescribing these HIV medications and recommending new medications or, telling you certain things, really what we look at, myself included, what we should look at are recommended guidelines. And there's guidelines for everything. These are not unique to HIV, right? But if you were to say, well, how does my doctor know, what medication to treat me for my high blood pressure? The answer is there's guidelines, right? So who comes up with guidelines? So these guidelines for HIV, there's guidelines that exist for how to treat HIV in adults and adolescents. And there's also guidelines for how to treat HIV in kids. And there's guidelines for how to treat opportunistic infections. And there's guidelines for every single other thing that you can possibly imagine. And these guidelines are by expert people, like the best of the best, the cream of the crop, right? So these are experts from across the United States who come together and say, you know what, in general, and these are recommendations. So the first thing to keep in mind is that these are broad recommendations for people in general. And sometimes your doctor is going to want to tailor these recommendations based on what they know about you. But as a starting point, all doctors should really have and know guidelines, guidelines for what they're treating. And in this case for HIV. And I wanted to just highlight this. So this is who makes up the HIV treatment guidelines. And I thought this was kind of cool. So the first thing you can see here, if you look on the scientific members, you'll see here the third name down is Kurt Beckwith. And you'll see that the 10th, the 8th or 9th name down here is Dr. Susan Kulovin. And you'll see over here on the right hand, Dr. Rami Cantor. So we have, and this is just to highlight that we have some really nationally renowned HIV experts. And those three individuals from Brown are on this national committee deciding what to recommend for all HIV people in the entire United States of America. So kudos to them first off. Kudos, to the fact that we have such a strong HIV program here. And you can see the other people here. And I think one thing also to highlight on these panels, you can see on the right-hand side, there's community members. And there's people from other organizations throughout the US. And you can see community members, there's 5 of them listed. These are from different community groups and different advocacy organizations. And so that's good news. So the first thing also, I just want to highlight that if you ever have issues on a policy broader scale, grab Dr. Beckwith's ear or Dr. Kulovin or Dr. Cantor. Because they are having a say in this, which I think is kind of cool. And I think it's also kind of cool that there are community members on this, et cetera. And so this is a huge document. No one should really read it, but it's like, 70 or 80 pages of dense space. But if you look, I just want to throw up this one example of what's in it. And you can see here, these are key considerations and recommendations. And you can see here, they're recommending for a person for ARVs for a person with HIV generally consists of 3 drugs, including an integrase inhibitor. And if you scroll down to the 4th bullet point here, you can see what regimens are actually recommended. And you can see that there's bictegravir, tenofovir, alafenamide, and emtricitabine, right? So that's Biktarvy. You can see here that DTG, dolutegravir, or Tivicay, plus abacavir, plus 3TC. So that's Triumec. So you can see here that these are where we know what is recommended to start. And there's a lot of background here, et cetera. So when I see someone in front of me who's newly diagnosed, this is what I'm thinking. I'm thinking, personally, I usually reach for Biktarvy because one, it's recommended, but it's recommended for a reason, right? It's recommended because it has great efficacy and it's very safe. And by the way, there's lots of pages. There's other sections about how to treat treatment experienced people. There's about what lab tests, how often people should follow up. So these guidelines really cover everything. Again, this is a good starting place, and your doctor will go over them to really tailor them to your needs. So I'm going to pause there. Before we go on to the next question about side effects, but any questions from the group about this at all? Anything anyone wants to add? I know there's some experts in here as well.
Yeah. Hello, Dr. Chan.
Hey, Tyrone.
How you doing, Dr. Chan? Okay, so I am a very proud and outspoken advocate of HIV, of HIV living. So when I first was diagnosed 20 years ago, I was taking those prohibitors that just showed earlier, the Crixavan and the other stuff. And like I cringed when I seen them because they made me sick. The side effects were they made me sick. So I had to, and that's when nobody knew nothing really. They wasn't sure what to give us. And they had to try things until our immune system could stand to take or reciprocal to whatever they was giving us. So when I just seen that screen with all those old pills from the old days, I just cringed because I got sick and I said, man, this is not going to work. I'm going to die because, they're giving me something that is not helping me. But finally they got it right. And as a result of the team, I don't know if you was there or not at the time, but as a result of what they did for me back then, they kept trying until they got it right. As a result of that, I've been non-detectable over 10 years, and I thank God, I thank the team for that much. So if that's the only comment that I can say today, that's the way I feel. So yeah, it's a lot of work, and I appreciate anybody that is involved in AIDS research or HIV research and all that. So yeah.
Well, thank you for that, Tyrone. Thank you. Yeah, we've come a long, and I think just on that note, and to your point, we've come a long way. We've come a long way. And to get a medication now approved for HIV treatment, it really has to be safe with minimal to no side effects. And I think for those of you that know anything about Biktarvy as an example, it really is well tolerated. I mean, people, have minimal to no side effects. So we've really come a long way. One pill once a day. I mean, if you think about it, it's really, it's really amazing. And I have my last slide here. I'll talk about where we're going as well for treatments, which is also very exciting. So I'll move on here. The next question here is, are there significant ARV side effects? And so the answer is, I think, is Tyrone, and this goes right from Tyrone, your question. The answer is yes. If you look on the right-hand side first, historically, there were a lot of really bad side effects. In fact, on that first slide with all the pills that I showed, right, there's a number of pills that are no longer even used or approved in the US because they had so bad side effects. I think when you look at the medications now, they're generally really safe. Some of the medications have some side effects. I think the biggest things that we are worried about now, if you look at tenofovir, right? Tenofovir is Truvada, it's Descovy, it's in Biktarvy, it's in a lot of different combinations people are on. In general, it's a wonderful, wonderful drug. It's what we use for PrEP, right? Pre-exposure prophylaxis. The biggest things that we worry about are it can affect the kidneys and it can affect bone mineral density over time. Now, how much do we really worry about that? And the answer is we don't worry about it much at all. I think I've stopped maybe 2 or 3 people in a decade because I was worried about their kidney function and tenofovir. And what I tell people actually, what usually happens in the scenarios that I've seen it, is because people already have kidney problems and they're on tenofovir, and the tenofovir makes it worse. So the tenofovir doesn't necessarily cause the kidney problems, but it makes it worse. So I'll throw that out there. It's not, again, it's not something I would lose sleep about, but that's why we check in. That's why it's really important to check in with your doctor, every, 3 to 6 months, so we can check things like kidney function to make sure that tenofovir isn't affecting it. And in most patients that we see it's a slow decline over time. And so, if we were to see it, then we would have to consider stopping it and have that discussion. The other commonly used NRTI medication, abacavir, so that's part of Tivicay. I'm sorry, that's part of Triumec with dolutegravir. So abacavir, there's a blood test you want to make sure that your doctor checks called HLA-B5701. There's a small subset of people that have this HLA gene that leads to what's known basically an allergic reaction to abacavir. So we want to always check that as a blood test first before starting someone on abacavir. And then there's some of these other drugs, like atazanavir. Hopefully, there's probably not a lot of people taking that. Hopefully, there's no one that's taking efavirenz anymore. But those drugs used to have some significant side effects. Efavirenz used to cause a whole bunch like dizziness and neuropsychiatric stuff. We also see some mental health. Oh, is there a question? Nope. Okay. We also see some mental health in small number of patients with the integrase inhibitors. That would be like bictegravir and dolutegravir. There is some reports of increased psychiatric disease in those folks as well. And then on the right-hand side, you can see that some of these, what I tell patients is that any medication can have any side effects. And sure, we see lots of weird things. But again, I'm just reminded that these newer drugs especially are in general very safe. But all these drugs do have a little bit of a side effect profile depending on what. So I think this was my only slide for the side effects. Happy to answer any questions if people have specific questions about any side effects. I know there's kind of a lot here. And also keep in mind, the other thing too, to remind folks is that for you is that, everyone reacts to medications a little bit differently. If you are on a medication and it's making you feel terrible or bad, or you're having side effects, a person should check in with their doctor to see about changing, because a lot of these, I've seen a lot of people that have, had some reactions to some meds and not to others. So sometimes it's about finding that sweet spot about what works with you and your body. This was another great question. What can we eat? What do we stay away from? We hear different things from different professionals. So what a great question. So, so just related to health in general, right? There's so much in life that we can't control. I like to really focus on the trio of things that we can control. So what are the most, well, sometimes I say 4 things, but what are the 4 most important things that one can do for your health? And hopefully, I'm not offending anyone when I say this, but really one of the top 1 through 100 things that you can do is don't smoke. So I'm sorry if anyone here smokes, but the hospital is filled with people that smoke tobacco. So I want to strongly encourage folks to really, really consider, like number 1 through 100, like just try to cut down as much as you can, chat with your doctor about tobacco, different cessation. It's really, trust me when I say the hospital is filled with people that smoke. So just not smoking will add years and years to your life. And it can be really bad in some people, not everyone, but in some people, especially when you develop COPD due to tobacco and get into the hospital, it's like suffocating. I mean, it's really a terrible thing at the end. And I'm not saying that to scare people. I'm just saying this to be realistic about tobacco. To me is one of those things as a lifestyle choice. And I understand that it can be addicting and it takes multiple times to quit, but it's one of those things, certainly for all my patients and just in general, from a public health standpoint, I would say really do your best, if at all possible, to cut down. then I think about other things, and I like this. And so I think this was what the question was getting at. But the other things that you can control, of course, to some extent are, diet, exercise, and sleep. Don't forget about sleep. Sleep is so important for so many things. But when I get asked, Doc, I mean, I'm looking for some, some diet tips and nutrition tips. This to me is really the simple, the way to think about it. And the answer is, if you look at this, and this is put out by the, the FDA, the USDA. And if you look here, right, 50% of any one meal should be fruits and vegetables. And so I think what has happened in our American culture, right, is that fast food is everywhere. I mean, how many people have been out to fast food, in the last, week, month? I mean, everyone has, right? It's everywhere. And so when we think about nutrition, and when I say diet, I don't mean, let's go on a diet and lose some weight. I mean, what are you eating? So I use kind of diet and nutrition kind of as interchangeable. But it's really a culture shift from the American culture where we, the majority of your food, should be fruits and vegetables and protein here. And you see grains, right? Most of your grains should be whole grains, right? So we're not talking about white bread. We're not talking about white pasta. We're talking about really fruits and veggies, right? And, protein, ideally, not ideally lean protein, like, ideally chicken or fish, and, red meat once in a while. So this is what you should do in an ideal world. Now, none of us do it. Do I do this? No one here does this. But, you have to do it sometimes or more often than not, right? So it's, everyone cheats a little bit, but it's setting in your mind, creating a culture with yourself about doing this and trying to do your best, eating things like fruits and veggies and only buying that, if you will, and really changing how you eat. And, I speak from experience. I mean, I lost 30 pounds about 5 years ago, with a radical shift. I had to change a lot of how I ate. I was overweight. I was starting to feel it in my bones and joints, and, I'm getting old too. So I had to make some major nutrition changes to get me through it. So I hope this answers the question about what do you stay away from. When I'm chatting with people too, the first thing I say is, I'm like, look, there's a few things that we all know that we probably shouldn't eat, right? Processed stuff and like soda, right? So I usually, when I first talk to people about nutrition and lifestyle, I always say you never want to give everything up at once, but you probably have to give up or at least cut way down on one or two things. And some of the things that I find that people generally eat a lot of are fast food, soda, right? Extra size, supersize me coffees, multiple coffees a day. So I usually just advise people to start cutting down in those area, candy, the sweets, things like that. And just to start to substitute some stuff into that, to just be healthier. So I hope that answers that question. Any other questions about that?
Oh, wait, I got a question.
Please.
Hello? I got
Hi,
a
we can hear you.
question. Yes, this is Christina. I'm calling because I heard of a new drug. I don't know if you heard of it yet. You should have. But it's a needle. You get the needle once a month or every other month. I don't know who all heard about it. But have you known anybody to be on that drug?
I have not yet. I know that it's was just approved, I think, not that long ago. I know that there's been some interest in it. And I would say that even with those drugs, right? So I don't have an opinion on it. I have to learn more myself. But remember, there's no medication that's going to fix nutrition, right? So I think it could be a good thing to lose some weight, but even with a medication that could help with weight loss, a person should generally still try to do some of these tips and to eat right, because there's no pill that's ever going to replace just eating right. But I'll have to learn more about it.
Okay, thank you.
Good question. Okay, I'm going to move on here. This was a related question, also an excellent question. should people be taking supplements when taking HIV medications? And if so, which ones? Great question. So I would say, and I'm very supportive, and certainly my patients, that in general, I would keep in mind that it, also in our American culture, it seems always like taking more is better. But that is not the case with vitamins. In fact, there's many studies, not in people with HIV, but there's many studies that show that if you take too much of a vitamin, it's actually bad for you. In fact, there's several studies like that. So keep in mind that more vitamins is not always better. That's one point. The second point to say is that it's always best, if possible, to get your nutrition from whole foods. So I know, again, it's tempting to just take a pill and fix problems. But what we've also learned through time is that natural foods, whole foods, unprocessed foods is always best to get your nutrition. So I'll start with those sort of two tenets. That being said, it's also known that it's important to get, and certainly in folks with HIV, to get enough of a vitamin. So I am supportive of recommending folks to take a single adult multivitamin daily. And that generally gets all of your essential vitamins at 100% of the recommended levels. Plus, with eating healthy, that should be more than enough. For folks that want to do more, and I think especially for older folks and folks on tenofovir, remember, tenofovir will take your bone mineral density down a little bit. I would recommend probably supplementing some calcium and vitamin D. So calcium and vitamin D, both are very common. Again, especially if you're older, especially potentially in older women who may have less body mass and less muscle, especially if you're on tenofovir-based medication regimens. Also for cisgender women, you may want to consider iron supplements. And then I also threw on here, it's important in pregnancy for folic acid. I also want to include the caveat that you want to be careful of other supplements. Again, to my point that more is not always better. And there's a lot of other, supplements out there like St. John's wort and other supplements that can actually have negative interactions with one's liver, with some of the medications, et cetera. So I would generally suggest avoiding other supplements, unless, of course, you talk to your doctor, but also keeping in mind for some of these other supplements, there's not great data. Any questions about the supplements or anything here? I know this seems really basic, but again, it goes to my point that, again, nutrition is critical, and really the basic multivitamins, like multivitamins, calcium, vitamin D, iron and folic acid in some groups are really, they're the most popular ones that everyone here has probably heard of, but they're the most popular for a reason. Like, they're the ones that work. I would generally, stay away from some of the other, supplements like St. John's wort because they can interact with medications, et cetera. Any questions about this at all?
Yeah, I have a question.
Please.
On the recommendations, it's saying multivitamin supplement. I didn't realize that you could get a supplement without iron for multivitamin.
You can, yep, you can. You can, yep, and it should stay right on the label with iron or without iron as well.
Because I know, like in the past, I've had iron problems, so I usually have that one. That's why I was surprised when I saw that.
Yes, double check if you have iron problems. Definitely double check the label, because there are a significant number of daily multivitamins that do not contain iron.
Oh, okay. And also where it says on others to consider, and it says iron, it says cisgender woman, what does that mean?
It means, so great question. So let me back up with the gender terminology. So when we generally talk about transgender men and women, right? So a transgender man, for example, is someone that was born female with a vagina, but now identifies as a male. So cisgender actually means you're the same gender that you were born with. So for example, I was born with male, as a male, and I identify as a male therefore I'm cis or same gender.
Oh, okay.
Sorry.
That's okay.
Good
And
question.
also, I know that like, because I mean, I've taken vitamins before and I know different medications I was on, I know that I had to take calcium because, or had a supplement because of the fact of the bone density thing with some of the medicine I was on. So, I mean, like some of the HIV med I was on. So I had to make sure I did have a calcium supplement to you know, supplement that part of it.
Absolutely. Exactly. So you can't really go wrong with taking a multivitamin and in general, calcium and vitamin D. So those are kind of the basic ones. Those are evidence-based, proven. You just don't want to overdo it. Even with calcium, if you take too much calcium, it can cause problems. So you want to stick to the recommended amounts by your doctor, by what's recommended by the government.
Yep. Thank
Yep.
you.
Yeah, great questions. So here's my favorite slide. What's new on the horizon? What's coming down the line? What should people be aware of? So the good news is there's lots of good stuff coming down the line, lots of good advances. So the first part is, you know, some of you may be aware that there's new medications coming out all the time, it seems like. And the good news is that there are new medications coming out all the time. So this is good. I will say we are still careful with the first line medications because they still tend to be so good. We don't want to burn them. We don't want to create resistance. But you know, a lot of attention now is being focused on long acting pill medications and other formulations. And what does this mean? There may be a time in HIV treatment where you can take a single pill once a week, once a month, once every couple of months, a pill, not a shot, a pill. Some of you may know that there's some injections that have just come out where you can get an injection every couple of months, and people are working on things like patches and implants, etc. So I think that it is an exciting time, and I think that there's a lot of, you know, research in this area, and you know, we're going to have both for HIV treatment and prevention at some point. It may be that you need to take a pill once a week or once a month, and there may be different ways to get it. So I think that that's exciting. You know, another thing I just wanted to highlight is this thing of broadly neutralizing antibodies. Some of you, you know, this whole COVID thing, I feel like there's so many parallels to COVID. But you know, the monoclonal antibodies for COVID, you know, there's this treatment for COVID where you can go in and get an IV infusion. People aware of that? Maybe, maybe not. Anyway, they're called MABs, monoclonal antibodies. And it's kind of getting to the point in HIV where there may be infusions that you can give people every few months of antibodies, which will essentially suppress HIV. And so this is another thing that's being worked on. I'm a little bit more skeptical of that just because it involves an IV. You have to get like an IV infusion potentially. So I'm not sure how feasible that is, but it's something being worked on. And then I think the most exciting thing to me, if it works, and hopefully it will, are what's known as therapeutic HIV vaccines, right? So when we talk about vaccines, usually we talk about vaccines to prevent something, right? Get your flu shot, it's going to prevent the flu. Get your COVID shot, it's going to prevent COVID. Well, people are also working on vaccines to treat things like HIV. And so the way that this would work is if you have HIV, you could get a vaccine, and the vaccine would actually stimulate your own immune system to attack and suppress the HIV all the time. Right. And so basically you wouldn't need any medications because you get a vaccine, and the vaccine itself would stimulate just the right parts of your immune system where your HIV would be undetectable. It's actually off medications indefinitely, hopefully, would be the theory. So I think all these are very exciting, and I think certainly reason for hope. You know, a therapeutic HIV vaccine would essentially be like a cure, right? So you would be off medications and virally undetectable, hopefully for forever would be the goal, lifelong. So a lot of exciting stuff. I think that was my last slide. No, I had, you know, we still hope to get to 0 new HIV diagnoses. I kind of just ended on that, but happy to answer any questions about the treatment. A lot of this is still in development, probably, you know, years away, but very promising, I think.
Yeah.
Any questions? Does anybody else have any questions or comments they'd like to share or ask?
I have one more question. It doesn't pertain to me, but I'm just curious. As far as the formulary with ADAP, do you know, like, because I've heard of Cabenuva, is that on the formulary or is that totally different?
It's on. It is. I don't know if you guys can hear me. It is on.
Okay.
So
We can hear you.
what I'm going to do, just so you know, because that's a great question, and thank you, Phil. That was awesome. This is Paul with an N95, so I may sound like I'm in the tunnel. So when a drug is FDA approved, we begin the process of vetting it through our clinical partners because we want it to be put on the formulary as soon as possible. So we work with the Medicaid program because I'm an administrator there as well, and the ADAP program to get you the drugs on as quickly as possible. So we're a state that really has very little lag time with getting a drug on. So it's great, Phil, that you mentioned the future because we always keep our eye on that so that we could be one step ahead of everybody by trying to just get the FDA approved drugs onto our formularies quickly.
And I'll say
sorry.
from the doctor perspective, I think that the Ryan White program does that very well. From what I've seen, we're very early adopters of these new medications, et cetera.
It helps that I was trained by the folks at Lifespan to do that quickly over 30 years ago. I'd have to give credit to Dr. Carpenter, Dr. Flanagan,
Yes.
Dr. Rich, Dr.
Yes.
Kaluban. In the very beginning, we just made a pact that as soon as something new came, and of course, those were the days of AZT. And that's all we had, folks. But we made a pact together that said we would be quick to the draw, not only with getting new drugs on, but getting people on the drugs when they were filling out their forms for ADAP. Right? The last thing you want is to delay, particularly, I think, Phil, you'll agree, a new diagnosis. You don't want them to wait weeks to get their drugs. So we turned that around very, very quickly in this state. We're super proud of that. We got a rating from HRSA saying that we were one of the quickest states to turn people around. So we're very proud of that.
Thank you, Paul.
Okay,
You're welcome. We do it for you, Jean.
all righty. Any other questions or comments? Calls for interpretations or elaborations? If not, why don't we give Dr. Chan a wonderful round of applause?
Thank you very much. And I just want to
Thank
echo one
you
of
so
Paul's
much.
points too. Back to Paul's point about all these people. I mean, it really is a team effort. I mean, I was trained by Dr. Carpenter, Dr. Rich, Dr. Flanagan. It is a team effort, and it's how we are addressing this together. So, I know I speak for Paul and Garlette too. I mean, if there's anything ever that we can do, please do reach out to us. I mean, we are committed to addressing HIV in the state, and we've made a lot of progress. We still have ways to go, of course. But again, it's really with everyone chipping in is how we're going to get there. And we are getting there.
Awesome. Thanks again, Dr. Chan.
Thank you all for your work. Thank you.
All righty. I'm going to turn it over to Paul Liberty, who's going to move us to a conversation by asking several questions regarding HIV or the lesbian, gay, bisexual, and transgender communities, aging, wherever you're comfortable. You can, you know what? It may be comfortable. It may be best if you come here so that they can see you and I'll relocate. Okay? Yeah, if you sit here, they'll be able to